You're listening to the 40 Fit Radio podcast, dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation.
Welcome back to 40 Fit Radio. This is Trent coming back for another episode. I'm also here with Coach D, and we're going to go into part 4 of our series on lower back pain. So we've talked about the theory of lower back pain. We've talked about some of the science behind it, some educational materials that you can use for yourself if you're dealing with this or with some of your clients, patients. And today we're going to talk about some practical recommendations for how to train someone that's dealing with chronic or acute lower back pain. So Darren's going to walk us through his model and his basic approach to handling someone. And man, Darren, why don't you just get us kicked off?
Yeah, great. Great for being here,
Show
guys.
us the way.
And yeah, welcome back to the 40 Fit Nation today. This has been a long journey. This is, like Trent said, this is our 4th episode in this. And it's also a constantly evolving topic, in which I think it should be, as our knowledge base is improving, as we're learning more, we're working with more clients, we're seeing what works, what doesn't work, what might not necessarily not work, but what works more effectively in some areas. And so this is, we're all learning here. We're constantly evolving in our knowledge base. Low back pain, or back pain in general, is something that we don't really know a whole lot about. We don't really fully understand it yet. Why do some people hurt and they have perfectly normal MRIs, and why do other people not hurt at all and they have horrendous diagnostic scans or MRIs? And so remember, folks, you're not your MRI, though. Today we're going to talk about the exercise intervention that I use both in the clinic on an orthopedic basis, in a physical therapy model, and also the very similar model that I use in the gym when I might have a client that injures their low back, whether it be during training or in their daily life. Now, one thing I want to set as a disclaimer first is this. We've talked about in prior episodes, and I would highly recommend that you go back and listen to episode 1, 2, and 3 of this series, and then listen to this episode and follow up if you haven't listened to those episodes in the last several weeks, because we've broke it up a little bit with other episodes, one on competition and one on coaching. And so now we're finishing this. So listen to them all in their entirety. You'll probably hear a similar thread throughout all 4, but what also you're going to be able to do is piece the puzzle pieces together a little bit better, and it won't be as disjointed as we hope it's not. So
yeah, and just a quick reminder for those of you who want to read deeper into this, we've posted a number of articles and studies that we've referenced in these episodes. Those are in the show notes for each of these episodes, so make sure you go read the show notes and check out. For this episode, we'll have definitely 4 or 5 articles to post as well. So, and eventually we're going to build a library of material on 40fit.com that you'll be able to search through. So as we build more and more episodes and different topics, you can go in and it'll be a good reference place for you.
Definitely.
So.
Yeah, I mean, the goal is, and obviously it's difficult to put something in print because if it's in print, it's old. There's new data, new knowledge.
It's always evolving.
Right, and it is always evolving, but it doesn't mean because it's old that it doesn't have value. We just may have better information, and we may not. But we're going to try to always bring you logic and reason and science and experience over fads and trends and gimmicks. And so that's the goal with 40 Fit, especially with our older population. And so today we're going to talk about the exercise intervention. And I first want to say this. Back injuries have a myriad of different presentations, meaning there are many different types of structural back injuries, and there are different types of back pain. It is very, very, very important that you as an individual, the listening audience, whether you're a lifter, a CrossFitter, a runner, a swimmer, a triathlete, ultra marathoner, whatever your chosen sport, that you get an accurate diagnosis up front immediately after an injury or an incident. An accurate diagnosis is very, very important. That accurate diagnosis, differential diagnosis, then will set you up to be able to then best treat yourself or seek treatment from a professional, whether it be a physical therapist or a coach who knows lifting or has some experience with injured lifters. But it'll give you an opportunity to be treated in the right manner once you know the etiology, the source of the problem. Extremely important. Now, also, after you get that accurate diagnosis, it's very important that you start treatment immediately. Rest is very seldomly the recommended path for, I would say, 80 to 90% of my population. I'm seldomly going to be recommending nothing but just rest, bed rest, or don't lift, or don't move, or that's just almost non-existent. And if it is, it's usually because there's a severe injury, there's structural integrity issues, and we're trying to give the body a little bit more time to deal with some of the acute trauma of the injury. So, but that's very seldomly a problem. So the number one thing that I want to also reference here is we can be talking about several different types of low back pain here. We could be talking about acute low back pain that has occurred immediately following an injury. We could be talking about a condition that happened, several days ago or even several weeks ago or months ago based on the severity, and it could be subacute. And it's all based on the timeline and the presentation of signs and symptoms. And then we also could be talking about a condition where it's more chronic. And in other words, it should have already healed within the appropriate chronology post-injury, and it hasn't. And now you're still dealing with ongoing symptoms. And we addressed some of the reasons why those symptoms might be there based on our prior episodes and conversations about pain neuroscience, central nervous system, sensitization, changes in behavior, changes in motor sequence, motor firing patterns. And so it's important for you to know kind of what you're dealing with. Is this acute, subacute, or chronic? Today, we're going to talk about both in types of conditions, chronic, and just about everything we apply today can apply to chronic, or all of it can. And then we're also going to talk about that acute injury where you just, you tweaked your back, you pulled your back, what do I do next kind of thing. So we're going to talk about that. Does that make sense?
Makes sense to me.
All right, good. So lots of information to present today. So it's going to take us some time to get through this, but we promise to not bore you to death, hopefully, and not geek you out on science. But we got several studies. Basically, here's the deal. Why you need to know what are the reasons why Coach D does what he does with not only his patients in a clinical environment, but also with his gym clients, his trainees in the gym, with the people that Trent and I work with here, Coach Trent and I work with here, and then also online clients or remote clients that we work with. So one of the reasons is 28 years of experience, just seeing hundreds and thousands of back patients. The second reason is personal experience as a back patient, 4 back surgeries, and experiencing what that really does internally to your personality, your behavior, your psyche, your function. The third thing is the academic knowledge that I have, the science that we apply to it. And then the last thing is also just a new ongoing knowledge base and learning from the larger community and learning what works with various types of patient or gym client populations. And so, there's a bunch of studies. I was reading through several of these studies. We'll have them in the show notes. The one that we've referenced several times in these 4 episodes is In the Spine or in the Brain, Recent Advances in Pain Neuroscience Applied in the Intervention for Low Back Pain. It talks all about the neuro pain science model, the difference between the structural model understanding and then also the biopsychosocial model that we now observe more often. Then we also have the effects of functional resistance training on fitness and quality of life in females. There's one on exercise and the management of chronic back pain. There's one on the effects of strength exercise and walking on lumbar function and pain level, and yada, 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 yada. One of my favorite ones that I just recently read was this one here, which is which patients with low back pain benefit from deadlift training. Great article, not real good science, but great article. And we'll talk a little bit about that today too. But basically what you should know is that we're reading the literature, we're reading the data that's out there so that we can present something that's science-based, but also very pragmatic and experientially based. So let's go through these scenarios. So the first thing is, let's say you sustain an injury. You've had a low back injury. You were doing deadlifts, or you were picking something out of the back of your truck, or you were at home working in your yard, or you just went over to pick up a pin that you dropped on the floor and you tweaked your back. Well, now you
threw out your back.
Yeah, slipped your disc. Oh man, we have a lot of jokes about that one. But basically, you have this perceived or experienced injury. Okay, 9 times out of 10, it's soft tissue. It's muscular injury. It's a sprain and strain of the musculature, tendon, and maybe a sprain of some of the ligamentous tissue. In some cases, there are also non-contractile elements that have been injured, and that might be the disc or the ligaments or articular cartilage or potentially the nerve root or even the spinal cord in some more severe instances. The model that we're applying today in regards to exercise is not applicable to the person that has severe lancinating neuropathic nerve root pain, muscle weakness due to nerve root pain, sensory changes due to nerve root pain, and dysfunction of movement, like they can't actually move, they can't extend their knee or they have a drop foot because they have nerve root compression, or other hard neuro, spinal cord, or central nervous system type symptoms. That patient is treated in a whole different fashion. Even though exercise intervention is very, very important, I'm not going to apply the type of I'm not going to have the direct approach that I am with that patient that I do with the patient that we're talking about.
Yeah, stakes are a little higher there.
Yeah, we're talking about the person basically that has a strain or a sprain of the musculature that's going to heal fine, or the person that maybe has chronic low back pain that is idiopathic in nature. It's non-specific. It's, some sore joints and, maybe facet joints that are a little tweaky. And they may even have some neurological symptoms. They may have some numbness that's intermittent or constant, but it's been there for 5 years. That's not changing.
Yeah, it seems like, sciatic nerve pain is very common.
Yeah. I mean, everybody says I got sciatica. Well, you and 100% of the population, we all have sciatica. We all have the sciatic nerve. What they're really saying is I have pain in a sciatic nerve distribution. That terminology is way overutilized in the clinic, way overutilized by patients. What they're really saying is my sciatic nerve is irritated or inflamed, but we have to figure out what that cause is. Many times it's something that we cannot improve upon. If they have foraminal stenosis, multi-level degenerative foraminal stenosis, segmental foraminal stenosis, I'm highly likely I'm not permanently going to make that foramen bigger without going into their back and basically doing a foraminotomy, opening that hole, reaming that hole out bigger so that I give more access for nerve root space. Now, I can do things like traction, inversion, manual therapy. I can stretch musculature where they're really, really tight and maybe they're overextended. Maybe their hip flexors are crazy tight. We need to stretch those out. So there's some things that we can do to mitigate some of that pain. But I hate to say this to our listening audience, but there are some cases where you're going to have some back pain and you're going to have a little leg pain every now and then. But what's your option? You're going to let someone go cut on you, and in many cases, your pain is not going to go away. So, and there's a balance there. Some cases are surgical. Some cases are best treated with low dosages of pain meds, and some cases are best treated with epidurals, and some cases are best treated with conservative care and exercise management. So, as
some of us say, what are you going to do? Not train?
Yeah, exactly. I mean, I always tell my patients, and I think we said this in a prior episode, you've got a choice. You can be weak and more painful, because that's what the data and my personal experience and professional experience sees in the clinic and in the gym, or you can be strong and less painful. And that's totally true to how the body works. And what we try to focus on is making you stronger and less painful.
You can take the blue pill and go sit on the couch with your Cheetos, or you can take the red pill and deadlift.
Yeah, exactly. So let's talk about how we respond to this. So basically, the first thing we do when we have that injury or when we have low back pain is we don't react. We respond. And there's a difference there. In other words, we're not going to react and catastrophize the condition. We're not going to think about the worst thing that could ever happen. We're going to educate ourselves and our client base and our trainees and our patients as to this is probably what happened. Take a deep breath. It's going to be fine. This is how we're going to address it. But we're going to educate them so we can arm them with knowledge so that they're not over-emotionalizing the situation too.
Right. And if you're a coach out there and you work with athletes and lifters, it's really important how you approach the situation. You know, if you approach this calm, like you've seen it a million times before, even if you haven't, that can make all the difference in how the lifter, it's kind of like a little kid, you know, everybody's got that experience when they're little and you scrape your knee, you come crying to mom. Well, if mom makes a big deal out of it, it's like, oh my God, you scraped your knee.
Yep.
Yeah, they just cry harder. Oh my gosh, this is terrible. Because they don't really know. They don't really know how to perceive that because they haven't really set that marker in their brain of like, is this really painful or not? They don't have enough life experience yet. But if you respond the opposite way, man, that sucks. You scraped your knee. Too bad.
Let's move on.
Yeah.
You know, it's really hard. It's really hard in the clinic and in the gym, man. I have to be careful because I've experienced back pain myself so many times and have treated it so many times, both in the clinic and in the gym setting, in both settings. And I have to be careful that I don't seem too uninterested in their problem. You know, remote clients, online clients, I have to make sure that they understand, hey, I hear you're hurting. Here's how we're going to address it. Yeah. And so I have to make sure that I don't under respond to in that scenario because they might not know what I know. So my job is to articulate to them, is to speak to them that, hey, you're going to get better. This is going to be fine. This is what's going to happen. Guess what? You're going to be sore. I kind of give them some things so that they're not wondering what's going to happen. I let them know it's going to be okay for you to hurt a little bit.
Right.
I tell my patients all the time, I give you permission to hurt. This is the normal response for injury.
And I think the key there, and this is an important point, is that it's what you're doing is you're educating. You're not necessarily, we're not treading into the realm of nocebo, right? We're not putting thoughts in their head and presupposing what they're going to experience. We're just giving them some education so that they're not freaked out and they stay calm when they do experience things.
Yeah. I mean, it's classical. You tweak your back, you pull a lumbar extensor, like a lumbar erector during doing anything, a functional thing at home or in the gym or at work or wherever. The first thing that's going to happen, your back's going to lock up into muscle spasm. You're going to get a muscle spasm, protective muscle spasm. The second thing that's going to happen is it's going to become more painful throughout the day because there's an inflammatory process that's going to build. As you move it, when you wake up in the morning, it's going to be hurt. It's going to be hurting, you know, and you're going to be stiff and you're going to be sore. As you move, it's going to get better throughout the day. As the day goes on into the evening, it's going to get worse. And then in the next morning, you're going to be stiff and sore again. And there's a cyclical progression of healing that occurs over time. And what we look for is a gradual descending trend in pain and dysfunction and an improvement in relief and in your functional level over time. And so, but it is a cycle. You've got to allow the body to adapt and recover over time. What I have found, though, is that we're going to talk about that right now, is the best way to promote that recovery process is movement. I mean, motion's lotion. We've talked about it, right? Is movement and the appropriate types of movement. But the first thing we do always is we educate our population. We educate our client or our patient or our gym member as to what we're going to do and what to expect. The second thing that I like to do is I like to address the symptomatic response, if possible. If they've seen a physician's got them on muscle relaxants, pain medications, anti-inflammatories, that's fine. With severe sprains and strains, there's not much you can do for that. I mean, the idea that everyone that's pulling a deadlift and tweaks their back can go right back to pulling deadlifts the next day, it's not It's not true. Not all people can do that. If they can't even get out of bed because the pain is so severe, then there may be a period of time where after the injury, where there's some recumbency. It might be, 24 hours, it might be 48 hours, it might be 72 hours before they really get moving again. During that time, our number one goal is to reduce pain, get them moving as much as they can tolerate, educate them, and reduce muscle spasm and some of the associated signs that occur with trauma to tissue.
Okay, so let's dig into that a little bit. Is there a specific sensation that you're looking for when you've reached that transition point of healing up in that immediate term? For instance, I've heard people refer to muscle tears as when you feel the pain starting to blur a little bit, that's when it's time to start loading the tissue. But before that, you've got to give it a little bit of time to heal before you start getting back into movement.
Well, yeah.
Is there another sign that's like that for lower back pain?
I think there's some occasions where you've got to give it a little time. There's other occasions where it's just a little tweak, and it feels pretty severe at the time. But if you get right back under the bar, sometimes that same day, or if you get right under load, or definitely movement, that same day or within the next 24 hours, it subsides immediately.
Okay.
And I've had that happen to where it just subsided immediately. But if it's severe enough to where there's acute muscle spasm and you can't, I've had times myself, and I've had patients to where they couldn't get upright. There was no way they were going to get upright. Their back was in such severe spasm. In that case, then what we're trying to do is reduce the severity of pain. And sometimes narcotics, pain medications, in short course, we're not talking about long-term usage, in short course, along with anti-inflammatories and counter-irritants and things like ice and e-stim and physical therapy intervention, those types of things, it can help to reduce the severity of symptoms, because our number one goal is to get the person moving again. It's to get movement started, because we know the faster we can move them with a certain amount of graded exercise that's appropriate for their healing cycle, the faster they're going to recover. So, I love what Mark Ripito has said before, and I agree with this concept. I think we have to be careful in really understanding the meaning of this concept. We're not waiting for it to heal. We're forcing the body to heal.
Right.
And what we're really saying is we're providing the right environment and the right stimulus to, when it does heal correctly, and most likely heal in a faster rate.
Right.
That's the goal. So what we're looking for is for the severity of the symptoms to become less localized and a little bit more blurred. So some people will say that they have this sharp stabbing pain in their low back, and whenever they try to get upright, it just locks them up. They can't move at all. That person is not going to be able to get under the bar. Period. It hurts too much. And they're not going to be able to maybe continue whatever their exercise endeavor is, if they're a cyclist or a swimmer or whatever. So you've got to treat those immediate acute symptoms. And then from there, that symptom severity is going to lower, and you give them a pain range. And I tell them 10 is you're dying. It's the worst pain you've ever experienced, and you would have already called 911. So if they come in and they say I have a 9 and we're having a conversation, they don't understand the scale.
Yeah, so you should be having a seizure right now.
Yeah, exactly. They don't understand the scale. So we try to right size their thinking about what the VAS, the number scale, really means, okay? And then we set that expectation level up front and we use that. When that starts to drop back to less strong and more of a moderate range of like 5 to 6 or 7, then I immediately start to get them moving more and more and more. Now I'm going to move them otherwise as best I can. And I'm going to talk a little bit about the exercise activity that I intervene with to do that, but it's going to be appropriate for their symptoms. Okay. If they're a chronic low back pain patient and they've had back pain for 5 years and there's been no recent incidents of exacerbation or other injury, and they complain of a pain level of 9, but I'm having a conversation with them, they get up, they stand, they walk, they get in and out of their car, we've got some behavioral changes to make.
Right.
Some modification in behavior and psyche to make, because they're operating on a very high pain perception level with a pretty good functional level, and we need to get them moving up on the functional scale and down on the pain scale.
So to sum that up, I think we can safely say that the chances are very high that you can move and do something. So go ahead and do that.
Yes.
And if you can't, you'll know it.
Yeah.
Yeah, you're going to know. And
Yeah.
then in that case, it becomes a question of degrees.
Yeah.
Let's wait till we get to the point where we can sit up and stand up again.
Yeah.
If you have that severe of an issue. But otherwise, movement is really the guide.
Yeah, and I think, like you said earlier, the symptoms blur. They're not as easy to pinpoint. You can't point your finger at the location. The severity drops. The symptoms blur a little bit. And it definitely begins to feel better with movement if you admit that self to yourself. In other words, if you allow yourself to feel the difference, that when you start moving, you feel better, you realize that you feel better.
All right.
Now, when you stop moving and you get more sedentary and you start moving again, you might have that transitional pain again, though, to where, you sat for a long period of time and then you get up out of the chair and you're pretty dang sore again, or that pain starts to go up again. That's not a sign that you're not getting better. It's a sign that you've been sedentary.
Yeah. And
your body is still in that healing phase and you need to get moving again. And so that's just natural. And that's the kind of education that we give people to say, hey, this is the experience that you might have. You may not, but more than likely you will. And it's normal. It's normal for the healing process. Right.
Absolutely. Okay. So we've got someone who has gotten to this transition point. Symptoms are starting to blur. The severity of the pain is dropping off. Now what do we do? Okay.
So now we're going to talk about exercise models. So the first thing I do with individuals, if they cannot go back to their exercise, the exact same exercise activity as they were performing previously. Let's say they were back squatting or they were deadlifting, or let's say they were doing cycling or swimming or running or whatever. Then the first thing I start them with is just bodyweight movements. Bodyweight movements. We use some other physical therapy intervention type things, everything from ice to e-stim to counter irritants to manipulation, orthopedic manual therapy manipulation, what people would consider chiropractic care, but PTs do it too. It's called orthopedic manual therapy. And we use some of these other things, stretching activities and everything. But when we're talking about exercise intervention, I start with bodyweight movements. And the first thing I start with is doing activities on their back. I might have them do, for resistance training, I'll start doing bridges with them. I'll also do some general stretches like single knee to chest, double knee to chest, trunk twist. And those are just basic range of motion things to just get their spine moving in an unloaded setting. The bridges add some loading to it. And the bridges, I'm getting to fire the posterior chain, the glutes, also the back extensors, the core musculature, the musculature of their abdominal region. So we're getting to fire those too. The next thing that I like to do too is I like to then take them to a sitting position, and we'll start doing some sitting exercises. So the first thing is sit to stands. It's a hip hinge motion, just like you would in a back squat. So we'll do sit to stands. When you tell patients we're going to squat you or deadlift you, they'll deny wanting to do it 100% of the time almost, unless they have a lifting background.
Sure. Yeah.
But when I say we're going to do sit to stands, they're like, oh, okay.
Yeah.
But it's the exact same thing, and we're just using body weight. The load that we're using is their body weight. Now, I'll tell you from being a back patient and having back surgeries that the first time you do a sit to stand after a lumbar fusion, you know that your back has been cut on. Because the first time that you break forward outside a pure vertical plane or a slightly leaning back plane towards your back, the first time you lean your shoulders forward and hinge at the hips forward, your back muscles contract at a higher level, boom, you feel the pain immediately from surgery. So what I learned through my own experience was how effective some of these real basic compound movements can be to start getting us to rehab this back and this spine. So sit to stands, teaching them how to hip hinge, using the back as a rigid lever. We keep the back in spinal neutral in all of these exercises because that's how the back really works. That's how the core, the trunk musculature really work, is in spinal neutral most of the time. Now, it doesn't mean that we don't move the spine. We do that with trunk twist, and we do that with cat and camels and other types of range of motion type exercises, but those are not strengthening exercises. So
now, and not to go down the rabbit hole here, but I think, do we need to worry about, as coaches at this point, looking for hyperextension in any of these movements as they're performing them? So
Yeah,
not
neutral.
going too far. So not going too far the other way.
Yeah. I mean, there's not a whole lot of danger there in regards to injuring them, but because the spine's very stable in both directions. But neutral is what we're looking for. So we want the spine to have a nice general. If the front of your body is anterior and the back of your body is posterior, there should be a slight convex curve to the anterior portion. We call that lordosis in the lumbar spine. There should be a nice gradual curve. Okay, it shouldn't be straight. And it shouldn't be flexed or concave to the front of your body, okay? It should be nice and spinal neutral, and that's the position that we're shooting for in any of these exercises. If someone begins to do a sit-to-stand and they cannot upright their shoulders enough through contraction of their thoracic and lumbar erectors, their back musculature, to keep their back straight because it hurts too severely, we're not ready yet.
Sure.
We're just not ready yet. They're still in significant spasm, significant pain. We need to get that pain down a little bit. So our form drives our function. I mean, it drives what we're going to be doing next. If they can hold the position and do it for if they can hold the position and do it for multiple sets and reps, and in this scenario, we might be doing 3 sets of 10, 3 sets of 15, even 3 sets of 20 to start getting them moving. And they can do that many sit-to-stands, boom, let's start adding load. And so then what we do is we start adding load. Now, if there's someone that we're working with in the gym, I might immediately go to a training bar, a very light bar. We have 12-pound bar in our gym. We have a 35-pound bar in our gym. I've got 25-pound bars in my clinics. And then we've got a 45-pound, just a standard bar. So I might even get them under the bar if I think they're ready for that. If not, I can use everything from a kettlebell to a dumbbell. I can front load the motion. I could even use a safety bar if I wanted to, and offset the load in that manner. But number one thing is I'm going to get them squatting. I'm going to get them moving and using their back as a rigid lever. The other thing I'm going to have them doing is what we would call a just classical hip hinge. Some people would also call that a deadlift. And so I use the term, we're going to teach you how to hip hinge today. That's what I do with my post-op patients. That's what I do with my low back chronic pain patients and everyone else and all my clients in the gym. And so in the gym, I use the term deadlift because they're cool with that. That's their world. So that they're cool with that. But I might even, if someone's in pretty significant pain still, I might be using PVC. And I teach them how to deadlift by having a high hip. The shank is slightly transitioned forward, just like we teach in starting strength. And that deadlift model, it's the exact same application. What's interesting was in some of these articles that I read, as background for this and as background for the articles that I've read for years, to develop the program we have, the spinal rehab program that we have in our clinics, and how I also work with gym clients, is that many times when they're assessing whether the deadlift works for rehab or whether this works or that works, they're not applying the appropriate movement model that you and I think of, Trent, as an appropriate deadlift stance. They're basically squatting the bar off the floor.
Yeah.
So they're back squatting to back squat in a high bar back squat, and they're squatting to deadlift. So they're basically squatting. Exactly.
Yeah. And it's, as we know, because we've studied this moment model, that makes a huge difference because, you're changing the whole group of musculature that you're training and what the prime movers are of the lift. So, yeah.
Yeah. I mean, if you're doing, you
just have to take it for what it is.
Yeah, exactly. The science is pretty clear. The physics of it's pretty clear. The lever arms are what they are. We don't, the low bar position is more effective, and the deadlift with a higher hip and a straighter shank with the bar over the midfoot is more efficient to pull that way. It's a hip hinge. So we start with the hip hinges with them too. So, and then we gradually increase that over time. I also like to use planks. I use planks a lot of times with these patients because they can't move a whole lot now and they are hurting. So we'll do short interval planks. We'll use forward planks first when they can do those with some reasonable lack of pain and stability. Then we'll go to side planks, and then we progress to longer durations over time. I'll also use bridges We talked about bridges earlier. I'll use the supine bridges, and then I'll put weight on the supine bridges too. And the other thing that I do in the body weight section, when we're talking, because most of these are just body weight movements to start with, that we eventually transition to load, to resistance. The other thing I love, and it's so simple, but all the research supports it, and that is fast-paced walking with an arm swing. Fast-paced walking with an arm swing immediately after a low back injury really helps to flush the area with a lot of blood flow. It gets them vertical. It gets them doing small rotations and flexions and extensions because of the way the spinal movements are coupled and the way that spinal segments move biomechanically. And it just gets lots of blood flow to the region. If you've ever fast-paced walked with an arm swing, you realize how tight your back gets after a while because you're flushing it with blood flow.
Right,
you're using every time you step down with your right leg, you contralaterally contract the opposite back extensor, and it's just a pump. It's contract, relax, contract, relax, contract, relax. So fast-paced walking with an arm swing combined with these body weight movements, and then other types of palliative things, ice and E-stim and counter irritants and non-steroidal anti-inflammatories. All those things help to get us moving quickly.
Right.
And that's all supported by educating ourselves as to the fact that this is good for us, that movement and lifting is good for us. Okay.
And so when you say with an arm swing for somebody who's performing this, is it similar to, when they say when you sprint, thinking about putting like your earlobes to your hip pockets and just think about pumping the arms rather than
it's just a normal arm swing. It's probably a little bit more. I like my patients in the clinic to have a little bit more arm swing than they normally would in a relaxing walk. So it's just like they're stepping.
So the harder you swing the arms, you're going to naturally increase the tempo of your
trunk
footstep.
rotation increases, flexion extension increases, side bending increases. So the back is moving, but it's in a vertical plane where there's less force on the back, where it's a little bit more comfortable. The more you start to lean over, the more contraction there is in the back, the more contraction there is in the posterior chain, the glutes and the hamstrings, and the more leverage there is being applied to the back. So the back's got to be ready for that. And it will get ready for that, and we will introduce that. That's what the sit-to-stands and other movements do. So we do that. Then from there, what we're going to do is we're going to progress right into resistance exercises. What's the timeline? It's purely based on the severity of the injury and the person's response to the intervention that we have. If we suspect someone has a severe lumbar sprain strain, and in 3 days they're moving relatively well with body weight movements, and they've got a pain level of 3 or 4 on a 0 to 10 scale, and they're doing all their daily living activities, we are not waiting. We are moving them forward. We're probably getting them under the bar. And we're doing it fairly quickly. And so from that point, we will either introduce, and I say this, some of my colleagues out there say this carefully too, but we might start them with a high bar. It just matters what their anthropometrics are and what their symptoms are. Most of the time, we'll just go right into a low bar squat. But I will tell you, post-operatively, in many cases after surgery, I will always, even when they're ready to squat, I will start them with a high bar before we go to the low bar. It just puts less strain on the back to start with. Not that the strain is a bad thing. The strain is a good thing when we can perform the correct motion. But all that's going to be dictated by their response to the intervention.
Right. They need to actually be able to perform the lift without major screw ups in form.
Proper mechanics.
Yeah. So do you find that the front squat is ever helpful in so far as being able to separate the fact that, hey, we're obviously doing something different than your normal, if they've been used to low bar squatting, for instance. Do you find that the front squat can help because it's not so close to the the low bar back squat?
Yeah. I tell you what though, the front squat, if I had to choose between the front squat and the high bar squat, I would choose the high bar over the front squat. The lever arm's just not quite as long, and it's not quite as taxing on the back. What I might do is do something like this. Front squat, I might do something like this. High bar squat, front squat, low bar squat.
Okay.
I might do something in that transition. Sometimes I'll just low bar squat them. I mean, if that's what they've been used to doing, and they're pain-free or minimal pain under the bar, and the pain gets better as they move, get them under the bar. Get them under a load. how much weight? We'll talk a little bit about how much resistance is resistance. We'll talk a little bit about that in a second. But I'll use everything from kettlebell squats, front squats to dumbbell squats, and I mix it up a little bit too. I have some rigidity in thought on what I think works the best, but I also think that there's some variance there. But the principles of resistance training and the principles of good exercise science are being applied. I can't say I'm really doing strengthening if I don't have a strengthening load. Now, what I can say is I'm doing rehab type loads. I'm getting them moving. I am getting blood flow. I'm doing more stamina work or more endurance work on the front end. If they can tolerate strengthening and there's a good response to it and they can tolerate true strengthening loads early on, we get after it. We go to it. But a lot of that's based on, your lifter or your patient is going to tell you pretty quickly what they can do,
So let's say we have a guy who's fairly strong or a gal who's fairly strong, has gone through an operation, and there's been some atrophy of the muscle tissue. And we've gotten to the point where the pain is now reduced to a low to moderate level where we're comfortable with getting under a load. How much at that point do you use bar speed as a guide for how much to load them, knowing that they're used to moving, that probably from a neurological standpoint, they've got an efficient nervous system that can move a lot of weight, but the muscle tissue just isn't there because it's atrophied during the recovery process.
Yeah, I mean, I've got to be careful with that person too, because they're
Is bar speed a relevant metric in that case?
Yeah, I think, form, bar speed, and time since surgery. Time since surgery is important, and surgical procedure. If they're a lumbar fusion, I'm going to treat them differently if they're a simple laminectomy discectomy, or if they had a facet joint injections, which is a surgical intervention. They're using injections, or at the facet, or if they're doing a rhizotomy where they're actually freezing or cauterizing that small nerve that feeds the facet joint to kill the pain. That's different than a post-op case where there's been structural integrity issues. In other words, I'm waiting for bone to heal. I'm waiting for, basically, for lack of better terms, I'm waiting for a fracture area to sclerode. I'm waiting for it to heal and the bone to become strong and for us to get good purchase of the surrounding musculature, ligaments, tendons, structural integrity of the tissue. So timeline after surgery is very important because it guides my efforts. And I'm not going to violate some of those healing timelines based on normal physiology.
Right.
I know how quickly bone generally heals. I know how quickly muscle and tendons generally heal. And that'd be a great podcast to just discuss the normal physiological time frames. So that's going to guide my decision first on a post-op case, a post-surgical case like you're talking about. But and you got to pull the reins back on that person a little bit up front. We have a fellow colleague who ruptured his quad tendon off of his patella.
Right.
Well, that guy wants to get under the bar as soon as the doctor says you can get in. I mean, before the doctor says you can get in the bar. But if he did that 2 weeks after surgery, even though he's feeling really good, or even 4 weeks, it may be way too early for the structural integrity of that tendon growing back into that bone. It's just not purchased good enough. It's not attached tight enough to do that. So we have to be careful with that person too. But let's just say in a typical sprain and strain or any other injury, I get them under the bar. We first do the bodyweight movement. Okay, that clears. That looks good. All right, we do it on the sit to stand. We do it on the deadlift or the hip hinge motion. All right, let's add PVC. Let's see how that feels. But I usually don't even use PVC. Let's add a training bar.
Empty bar.
Okay. Yep. Let's go to a 35-pound bar. Let's go to a 45-pound bar. All right, let's go to 60 pounds. Let's go to 75 pounds. And we just gradually work along the lines. And when they say, if I see form break down, or if I can tell that it's becoming quite a bit uncomfortable, we back off a little bit, and that's where we hang out. Now, there are also some schools of thought that you immediately get back them to higher loads, much lower much lower rep counts, and that you really get them to much higher loads. I think that's appropriate when there's very little structural damage, when the integrity of the tissue is good. If it's just a tweak, it's just a strain of the musculature, a type 1 or type 2 strain of the, minimal type 2 strain of the musculature. Yeah, rock and roll with them.
Yeah.
Get them under load.
I can think of, probably about 6 months ago, I was deadlifting And I broke up, I just because of the way the workout fell, I had to break up my workout to where I had to finish my deadlifts the following day. And I just kind of went in the gym and did my normal warm-up scheme and not realizing, you know what, I'm warm for the deadlift because I had squatted and pressed previously. So anyway, I just do my typical warm-up scheme, first heavy pull. Oh, man, yeah, strained something in the back, one of my spinal erectors. And so, yeah, we backed off to bodyweight movements for like a day, couple days. Then 2 days later, I was using a light, 135 pounds light for me. And within a week, I'm back up to lifting fairly heavy load, within 90% of where I was.
And that's a perfect example. Right. What we've done is, number one, we've ensured that you psychologically have a better chance to succeed because we've educated you. Number two, we've reduced atrophy and potential damage to surrounding tissue and also performance. We've definitely curbed the amount of decline in performance that's going to happen because of the injury. And number three, what we've really done that's probably as important as anything is that we've forced the area to heal. We've promoted the area to heal with appropriate healing, reducing the scar, improving the extensibility of the scar that's going to occur there. And really, we've actually avoided some of the scarring if we've loaded them appropriately, especially if it's just a typical strain sprain of the muscle.
Right.
So yeah, I mean, that's a perfect example. You and I had a trainee in the gym recently who pulled his adductor. Mm-hmm. And he was told by several people, don't squat or don't deadlift for several weeks.
Yeah.
We won't say who those people are, but he was told by several people not to do that. What did we tell him? You and I, we discussed it. And we told him, hey, we're going to get you right back under the bar. He believed in us. He was dumb enough to believe in us. And I think he's, we're how many weeks out now?
Yeah, he's within 90% of what he was lifting. And so we're about
3 to
4 weeks out from the injury. And exactly what you've outlined. Worked bodyweight movements to a box, so limited range of motion, worked to full range of motion at the bar. And and this is a guy... Masters guy squatting 325 when the injury occurred, and now he's back up to I think 305.
I was about to say, he's almost at three wheels now. So that same guy in the hands of most PTs and I don't think we're doing anything special. I think we're just applying science and experience. We're doing what we know works, and that's just why would I do anything differently? And so we talked about this. We're going to progress to resistance. We're going to start with the squats. We're also going to add deadlifts back in. We might also add, just for some more volume under lower loads, we might add some accessory work like good mornings, Romanian deadlifts, barbell rows, lat pull downs, chins, push-ups. I mean, all those things work on the core stability, quote unquote, the buzzword, the core, but it works on your trunk strength and it works on firing the musculature. I also, I like to get back into the press as soon as possible because it takes a lot of trunk support and co-contraction of the abdominal wall and the back extensors and all the surrounding hip musculature to be able to press heavy. Yeah. So I get right back into the press again.
And you can perform it with a vertical torso. So
absolutely. Yeah. No layback.
Yeah.
No hip drive. This is just a strict press.
Yeah. You think about that real long kinetic chain when you shrug out a press. Yep. And so that requires, like you said,
great stability, great balance. It's working the deep musculature very well. Several of the studies that you read today talk about the difference between high load, low volume training and low load, higher volume, meaning higher repetition training. So one is more, work the deep musculature and work the fine musculature. One is more, just put them under a deadlift and put some load on them. And both of them have promise and both of them have value. So I think the key there is you don't have to throw the baby out with the bathwater. But the number one method that I'm going to use to strengthen someone's hips is going to be the squat and the deadlift, period.
Yeah.
Now, if they can't squat and deadlift because of some other medical reason or some other mechanics reason, then I might have them leg press. I might have them do an inverted leg press or something like that. But we're going to get them moving in those motions, and that's in that resistance model.
Yeah, and let me segue there again. So let's say you're trying to get back to performing squats and deadlifts, but you're having trouble with pain tolerance, right? Your overall pain is low to moderate, and it's well managed, but actually performing the movement, you have trouble. you can always think of limiting the range of motion, but still using the same movement pattern,
Sure,
right? So instead
sure,
of going
sure.
from a squat and saying, I just can't squat straight to a leg press, can you squat to a box
Right.
and cut the range of motion out? And again, we have another trainee who's dealt with it's chronic sciatic nerve
Right,
pain,
right.
which we believe is due to some facet joint issues, compressing the nerve root.
Yeah. Well, actually, three things: probably obesity, large abdominal mass. Number two, hyperextension of the lumbar spine due to tight hip flexors and obesity.
Right.
And then number three, lack of hip mobility. And he's got some spinal stenosis, got some compression back there. It's pinching that sciatic nerve, that L5S1 nerve.
Right. And so he's got a lot of trouble in that last, I'd say, 3 inches of range of motion to hit full depth in the squat. But we've been able to squat him to a box and continue to load his hips, continue to load the back, but just to that point before it becomes painful. Yeah. So he's still getting some work. Without having to wholesale throw out the squat.
Right. And then we're dealing with all the other problems that we need to deal with. He's also deadlifting without any pain. He's pressing and bench pressing without any pain, chins without any pain. And then we're also working on, the advice that I gave him from a therapeutic standpoint, physical therapy standpoint, was we need to get some traction. We need to get some decompression on your spine, and we need to get your weight down, and we need to stretch your hip flexors out. All those things, get him into a little bit more flexion to open that foramen a little bit. And so, best case scenario, not everybody just gets back in the gym the next day, but not everybody also needs to have a lot of time off of their exercise too. So we're talking to the population, the audience out there that says, I have this chronic low back pain. What do? Start moving. Start gradually loading, start hip hinging, start deadlifting, start squatting, but get coaching, because all this stuff requires a certain amount of form adherence, adherence to good quality movement. And I think both Trent and I are really biased. I mean, we use a certain movement model that's been very successful for us. It works. And that movement model is the starting strength model. Now, when needed, we can derivate from that. We can go to a high bar back squat if we have to. We can go to a front squat, but we're still going to use good mechanics.
Yeah, the same model still applies, even
Absolutely.
if that's not our exercise of choice for the healthy person.
Yeah.
And I think there's some controversy, maybe controversy is not the right word, but there's some debate right now, some healthy debate about the impact of form on injury cause. Does bad form really cause injuries? But that's actually not relevant. I think the reason why we prefer to use this model is because it's repeatable.
Yes.
When you squat with a specific model in mind, you're performing the same motion, and so you can improve the same movement pattern every time.
And it's an optimum movement pattern.
Yeah, and from a physics standpoint, it's optimal.
Right. It's an optimal movement pattern that uses appropriate biophysics and just human anatomy, and that's key. And so, the last thing I like to do. So first of all, let's recap a little bit. Number one, we address the problem up front. We educate. Number two, we deal with any immediate acute symptom presentation with the things we talked about previously. Number three, we start immediate as soon as possible. Once the symptoms blur a little bit, body weight movement. If all they can do is walk for me, and all we can do is increase the walking speed, they're walking. We're doing that. And we may be doing that 3 or 4 times a day for 10-minute sessions. We might increase those sessions to 20 minutes, try to get to 45 minutes a day of walking. When I had my back surgery, the first thing I did the day after was my wife and I got my tennis shoes on. Once I got home from the hospital, when I had my lumbar fusion, and I am out walking the neighborhood. I only made 2 trips around the neighborhood, but I did that 3 or 4 times that day. And so the goal is to get blood flow there and get moving. And then from there, we're going to apply these body weight movements like we talked about, the sit-to-stands, the deadlifts, the planks, the bridges, cat and camels, range of motion, the walking with arm swing. All these things are done in a spinal neutral position, except for some of these mobility things. Then we're going to start using those same movement patterns and start applying resistance loads. So squats, deadlifts, the press. I tell you what, I really, really like. I like weighted planks too. I like weighted planks. I like push-ups, weighted push-ups. You get some upper body work and you're keeping that nice, rigid, hollow body plank position. And then you just start putting a little load in the upper back. The other thing I really like, and we didn't talk about this, was sleds and carries. I really like weighted carries. I like weighted carries down at the side. I also like one-arm weighted carries, like with a kettlebell or dumbbell overhead, to work on some unilateral balance and strength in the core or the trunk musculature. And then I also like pushing and pulling the sled. I think pushing and pulling the sled is really good for developing a nice, rigid, strong, isometric strength of the trunk musculature. And it can be done, and it's extremely, extremely safe, you know? And so it's great for stamina work of the trunk musculature. So are carries. Long carries are great for stamina work of the trunk. And so we do those things too. We're using all of these different exercise interventions really to do four main things. Number one, we're trying to increase blood flow at a faster rate than normal activity would promote blood flow to the region. So number one, increasing blood flow. By doing that, we increase all of the nutrition to the healing tissue. We increase lymphatic flow. We increase good hormones in the area. We increase the macrophage production so that the bad stuff gets pulled out of the cells. The waste from trauma gets pulled out of there. The white blood cell rate increases. Everything increases to the area. The other thing it does, it pumps that torn muscle or that damaged tissue, whether it be joint, muscle, tendon, ligament, whatever it is, with lots of blood volume, and that expands the tissue and allows the scar to be developing along the lines that we want it to be, being more extensible. And also by contracting the muscle back and forth multiple times, we are making sure that that functional unit of the muscle called the sarcomere stays healthy, that we're repairing it, we're using it, okay? So we're forcing tissue healing within that structural level of the muscle or the tissue. Now, if it's ligamentous tissue, we're waiting for it to heal, plain and simple. But even though ligamentous tissue has very, very poor neurovascular flow, very little nerve and blood flow into it, we can still improve the surrounding, I guess you would say, environment to that area to improve its healing, okay, and to accelerate that healing rate. The other thing we're doing is we are improving the motor sequence firing. We're ensuring that we are going to limit the amount of movement pattern deficiency, I guess you would say. In other words, we're keeping people from basically moving in a way that's pain related. Okay. Right. So we're trying to establish as much as possible normal movement patterns through the healing process. If we see an abnormal movement pattern, a lack of desire to want to extend the back in standing up, then we work on that and we address that. And then we go to an activity where they can extend the back. So we just step it back a little bit. Okay. And then the last thing would be we are reducing atrophy. We are ensuring that the area is going to heal at an accelerated rate. And we're increasing the stamina and the strength of the muscle at an accelerated rate. So we get a ton of opportunity here to help low back pain, whether it be an acute injury or a chronic injury. And these are some of the exercise activities that I use to do that. So again, to recap, the body weight exercises, then the resistant exercise, a lot of compound movements, and ensuring that the back is being used as a rigid lever the entire time, unless we're just doing mobility work or stretching, and then getting them rocking and rolling and moving along fast.
Yeah. Now, there's a lot of detail when it comes to actually implementing each
set
of these
rep
steps,
scheme.
Right? Sets and rep schemes. And, a lot of that is driven by your experience as a coach and what's worked and what hasn't worked as well. But one resource I want to point out to our listeners is this is something that's unrelated to what we're talking about now, but I think it's actually really applicable when it comes to what kind of mindset should you have as a coach or as a trainee that's trying to navigate through this day by day, is the minimum effective dose programming methodology, right? So it's just an idea that it comes from medicine that we use, and we've talked about this before in previous episodes on programming, that we make one change at a time. We change one variable at a time, and we try to make the minimum change necessary to drive progress. And so, as you're looking at, moving from a body weight movement to a loaded movement, there's going to be a lot of variation depending on the trainee and their training history and all that kind of stuff as to how much and how quick they can get there.
Sure.
So look for ways that you can incrementally move. So again, using the squat as an example, if a sit to stand is good to go, but a full squat, partial squat.
Yeah.
Right. Same thing with the deadlift, rack pull.
Yeah.
Right.
Sure.
And then slowly, and then instead of going from a rack pull all the way to pulling straight from the ground, maybe go from a rack pull above the knee to a rack pull below the knee.
Yeah.
And then then to the ground. So you can break down these transition steps into small incremental doses.
Yeah. No, that's a great point, Trent. And that's one of the modifications that we do with the deadlift. If someone can't get all the way down to the middle upper portion of their shin based on their body type, the way that they're put together, shank height wise and everything else, if they can't get that deep yet because their back just won't sustain that position, then we have them pull from right below the knee or maybe a little bit above the knee in a rack pull. And they just start there. They start pulling from the rack. We keep the volume low. We start loading that spine as quickly as possible to their tolerance. And we let the pain and the form and the response to the intervention dictate how fast we're going to progress that load. You're not progressing that load in a linear progression, a classical linear progression. Because let's say they were a trainee of yours and they were deadlifting 405 for fives.
Right.
And they tweak their back. Well, you're not going to start them back down at 135 and go 135, 140, 145, 150. What you're going to do is you're going to first, if they can't do a full deadlift, you might do rack pulls with the bar. And I might do 3 sets of 10 to start with, 3 sets of 15 just to increase blood flow, get them moving. But very quickly, if they tolerated that well the first day, all right, second day, we're going to start adding a little bit of load, and I'll start pulling back those reps some. So it's a gradual titration of bringing the reps down and bringing the load up until we're back to our traditional strength training scheme of 5 rep sets,
right?
Okay, with higher loads. And so we might go from 135 we might go from the bar to 65 pounds on the bar, to 95 pounds on the bar, to 135, to 155, to 175, 205. And within a week to 2 weeks, we're rocking and rolling, man. And actually with some trainees, we've seen that, within a week, or less, we're back to where we were before. Now, I know you see people that, they tweak their back one day and the next day they PR their deadlift. I get it, but I think the reality is that I'm not as interested in how fast that occurs as how well they're healed. I do want to follow some basis of normal physiological healing timeframes. And I know that muscle tissue, as an example, heals somewhere in around 14 to 21 days, with some of the final healing occurring farther out in weeks. But in general, within 14 to 21 days, the muscle tissue is relatively healed, so we can rock and roll with it. Now, if they had a huge hamstring tear, and they had blood everywhere in the thigh and it was swollen, it was hot, and that's a severe tear.
Right.
In 14 to 21 days, that's not going to be a normal muscle yet. It's going to take weeks but we're going to progress them in the same model, just using the signs and the symptoms and the response to intervention along the way and forcing the area to heal. So,
yeah, that's the beauty of the model. You can stretch it out as long as needed or shorten it.
Yeah. And people always ask me about set and rep scheme. I'm glad you mentioned that because, we've even talked about this within our coaching community and using the STAR rehab program when it comes to sprains and strains. And, this varies from coach to coach, but generally what I do is when I first started using this model several years ago and first learned about the STAR rehab model, which just made total sense to me, I would do the typical 20, 25 reps at 3 to 4 sets and 3 sets. And we would just continue to progress with the poundage increases as recommended. And then I started to realize that rep count might be a little high for some individuals. And so I started pulling it back a little bit. And what I find is if I can load them a little bit heavier, a little earlier, then I drop those reps down to more in the 3 sets of 10, maybe. Some I'll do 15, but I just play with that a little bit. I know even, I've talked to Dr. Will Morris, one of the PTs who's a starting strength coach with us. And I think his model is even a higher load with a lower rep scheme. So, I'm not so concerned with the exact, 6 reps exactly, or 4.5 reps or whatever with this many sets. But I think there's some concepts that we follow here. We know that strength is done in the lower rep scheme, somewhere between 10 and below. And we know that stamina is done somewhere between like 12 to 15 to 20-ish reps and endurance above that. And so that's kind of the general rep model in exercise science. And so if I'm really going to work on strength eventually, then I got to get the reps low and the loads higher. Yeah. And that's just the way it works.
Absolutely.
But at first I might be working more on just stamina, getting the muscle recovery in there and getting it moving. But at least I'm getting them moving, and I'm trying to retard atrophy as much as I can. Get them rocking.
Yeah, and one last thing on that point, I've also watched you in doing this. The same thing holds true for frequency. So when we're talking about the very first days of movement, when we're doing bodyweight movements, it's daily, and then over time, as the volume comes down, and then the loads go up, we transition back into whatever the normal workout schedule was. So if it's 3 day a week, 4 day a week, then you come from an everyday lifting to every other day, and then back to, eventually back to where you were on your program. Yeah.
At first, after an injury, people are doing something every day. They might not be lifting every day initially, but they're doing something. They're moving every day, and they may be moving several times during the day. When I start loading them again, in many cases, they're lifting every day. And then as the loads, like you said, as the loads begin to climb up and we get closer into some loads that are adapted loads, they're loads that are, that are going to require some more recovery.
Yeah, from truly causing a stress.
Yeah, they're an overload stress. Yeah. Then we drop it back to the appropriate frequency to 3 times a week or a 4-day, whatever the model that they're using is. And then we rock and roll with that. So that's kind of how it works. So it's a work in progress. I mean, we're a lab. I mean, we're constantly trying to figure out better ways to treat low back pain, both in the chronic and the acute and subacute populations. I'd like to say that we have some expert knowledge, but we're not the experts. I follow some of Stuart McGill's work. I like his work. I follow some of the people in my industry too that are PTs. Definitely follow. I think Mark Ripito has some great thoughts on low back pain. I've read his articles. And then some of the coaches within our community are solid resources. But in all of those models, we're all trying to use science to advance the way we mitigate the problems that occur and the damage that occurs from low back injuries and pain.
Yeah.
And that's the goal here.
Yeah, I think overall, if we can generalize there, really, when you throw out the fine details, these models are more alike than they are dissimilar.
Here's the deal. The deal. Number one, you haven't slipped a disc. Number two, you will go back to lifting more than 10 pounds for the rest of your life. If you've ever been told that you can never lift more than 10 pounds or you'll break your back, that's horrendous. It's inaccurate. It's not scientific. It's not good medicine. It's not good anything. It's not a good response to your injury or to your problem, whether it be chronic low back pain, injury, surgery, whatever it is. If you cannot get your body back to being able to use it in a useful manner, then we've got a bigger problem to deal with. And so, number two, you will get back to doing things. Number three, we're not going to catastrophize your injury or our own injuries or low back pain. We're going to educate ourselves as to why you're hurting, most likely, and how to retrain your brain, and also after an acute injury, how to think about back pain when you sustain it. So those things are drastically different than what you hear out in a lot of the public sectors, and a lot of the advice, quote unquote, air quotes, here we go, air quotes, the advice that you hear from your friends and family members. Oh, I did that and I had this, or I did that and I had this. Forget about that stuff. Most of that is inaccurate. Most of it's inaccurate. What we're telling you is this, is that you can have a back injury that's acute and quickly, 9 times out of 10, rehabilitate from it and get back to life very, very fast. Number 2, if you have chronic low back pain, you can treat that with strength training, and you should be able to get back to a reasonable amount of function in the ability to lift weights and do things using the spine as a rigid lever with proper form. And if you're not doing, if you're not having that experience in both of those 2 areas, then you need to come to see us, or come to see a starting strength coach, or go find a really good PT that believes in lifting barbells or resistance training in some form or fashion, and is not going to handle you with kit gloves, and is going to educate you as to how to get your back healthy again.
Well, there you have it. I think we did that one pretty good. So we're probably going to do more of these series on pain, not just lower back pain.
Sure.
I think there's
knee pain, elbow pain, neck pain.
Yeah.
Bone pain.
Brain pain. Yeah. I got some brain pain
Slipped
today.
a brain disc.
I slipped a brain disc today. So we'll talk about that. We might need a psychologist here for that one.
A psychiatrist needs some meds.
A psychiatrist, yeah.
Dang.
But yeah, I know. I think that we'll definitely tackle these problems with other areas of the body, because we've got a lot of things that are common in lifters and athletes, and we'll tackle that. But the model's still the same. Right?
Yeah,
the thinking
absolutely.
applies to everything, not just lower back pain.
Sure.
So I hope you all have found this series enlightening. Leave us your comments on our Facebook community, 40 Fit Masters community. Let us know what your experiences are. Maybe you're dealing with some tweaks yourself. It happens all the time. But share your experience. Tell us what you're doing, and drop us a question. Yeah, we'd love to help you out with that. Otherwise, go subscribe if you haven't already on iTunes. Check us out at 40fit.com. And otherwise,
Instagram.
Oh, yeah, Instagram.
Instagram would be at 40fit radio, and my personal Instagram is at DL Deaton, and Trent's Instagram is
at Marmalade Cream.
I'll
let you keep guessing what that is. Maybe someday we'll reveal the secret. Like, what is that?
Yeah. And then, you can drop us a line in whatever form or fashion you want to, but the number one goal is, we appreciate you guys. Thanks for joining us here on 40 Fit Radio, and thanks for being part of the 40 Fit Nation.